Shortness of breath. There are many conditions that cause shortness of breath, and we're going to talk about two conditions. One that causes a person's lungs to become scarred and stiff, and another condition that causes the lungs to break down and enlarge and trap air. You may ask, do these conditions make it harder to get enough oxygen? Absolutely. Hello and welcome to the Inside Scope, a podcast from Lakeland Regional Health, where we share insights from experts providing award-winning care in our community. I'm Dr. Daniel Haight, Vice President of Community Health at LRH, and I also have the privilege of hosting this podcast. With us on this episode is Dr. James Brown, a board-certified pulmonary and critical care physician seeing patients at our Grasslands campus and at Lakeland Regional Health Medical Center. He has cared for patients with lung transplants and has experience in treating patients with advanced lung disease that we're going to talk about today. Welcome, and I'm sort of started with a very common symptom that shows up in the urgent care clinics. It's almost like those really big symptoms like chest pain, severe headache. To me, shortness of breath, that gets people's attention. And we're sort of talking about the mild to moderate to severe shortness of breath. Tell me a little bit about the average person. When they notice they're short of breath, what's going through their head? What do they think is going on?
Yeah, and thanks for having me.
You're welcome.
Great radio voice, by the way.
Well,
I think you
thank
missed your calling.
Yes,
this is a very nice operation you got going on. So shortness of breath gets complicated because a lot of things can cause it. So it's the patient's perception of shortness of breath. And a lot of times patients get confused of thinking, oh, I need oxygen, I'm short of breath. But that's just addressing if low oxygen is the cause. So you think about that feeling of shortness of breath could be anything from a cardiac limitation, right?
So the heart, like if your heart is fluttering and it's a heart issue only, you may think that it's shortness of breath when really it's not.
Yeah, or if a valve is tight or leaky, or the right side or the left side is a problem and the heart has to work harder to do its job, you could feel short of breath just from anemia, right? It's not uncommon.
So if you're low on blood,
Correct.
you'd be short of breath, but your lungs are fine, your heart is fine. You're low on the red part of your blood, and you're going to be short of breath. Oh, I see. You're going to be short of breath.
So the red cells, their job is to take oxygen from the lungs. The heart pumps that to your tissues, and that's how they get the oxygen they need. So if you're low on your red cells, your hemoglobin, everything's working harder. I usually tell patients it's like asking Amazon to do the same number of deliveries with fewer trucks. Everyone's going to be tired, right? Shortness of breath could be muscular. There's diagnoses where the muscles are inflamed or weakened for a number of reasons.
And it's your muscles that really cause you to breathe. You got your diaphragm, and that's really and so if that muscle is weak for some medical condition, you're gonna feel short of breath too.
Yeah, correct.
What about folks that feel that this is just I'm having a panic attack when no, you're not, or I'm just getting old, or I'm out of shape. That worries me the most when someone wants to just go, oh, this is just me getting old, when it's like, no, this is not how 60, 70, 80, whatever your age is. What do you think about those two? Let's start first with, is this really just being out of shape, or not being being as young as you used to be?
Things like anxiety and being out of shape are what we call diagnoses of exclusion, meaning you wouldn't hang your hat on that as an explanation unless you've done a thorough workup to rule out all the things I mentioned and the lungs. So a lot of times patients, should have a sense of what activities was I able to do a few months ago or a year ago, and then how has that changed? So a common scenario will be maybe someone wasn't acutely aware of shortness of breath, maybe their family members mentioned it, and when you dig into this in the clinic, you say, were you likely to take the stairs 6 months ago, and now you're more likely to say, wait for the elevator.
And you may not have noticed that, but people around you might have noticed.
Correct.
And you might be just saying, it's just me out of shape and getting older. But when I teach medical students and I tell them, yes, the patient might think it could be this, this, and this, but working together, listening to the whole story, we are going to put at the top of our list the most important things. are you short of breath because of your heart and your lungs? And you mentioned other ones, muscles and other reasons. And I liked how you worded it. These other things are diagnoses of exclusion, meaning we considered all the real important things that you might not have thought of. And we want to reassure you, we've checked your heart out. Now let's look at your lungs. And today we're talking about the lungs, some very interesting diseases. We almost picked two diseases that are almost opposite. As it was in the introduction, it was like there's one disease we want to talk about where the lung is getting scarred and stiff. And then there's another diagnosis that's probably, I would say, a little more common, where the lung is not like it used to be. It's breaking up a little bit, it's getting larger, and it's trapping air. Which one do you think is the best one to start with?
Yeah, probably the trapping air, because it's more common.
Yeah.
And then when we're
Air's obstructed. It can't get out. That's what you sort of mean?
so
Like,
that's
it's
that's what
obstructed.
COPD is. Versus the interstitial lung diseases where the lungs are getting stiffer, less common, but frequently the patients are initially diagnosed with COPD. We dig in more and find it's like you mentioned, the opposite.
And I love the letters because it helps me think through what's actually going on. So when I hear the letter C, it often means chronic. And these are folks that it didn't just happen overnight. It's like you described. Family has noticed a little this, a little that, a little that. And then the O is obstructive. The air can't get out. I've seen people with COPD, chronic obstructive pulmonary disease, their chests are larger. And it's so slow of a change, you might not have noticed unless you look at pictures.
Yeah, so with COPD, if you think about the lungs as just a bunch of air sacs, there's an elastic nature to them. So breathing out should be effortless. You breathe in and then
because the lungs
breathing out
like a
is-
rubber band, the lungs like to get smaller and
Exactly.
the air goes out. So breathing out is the natural.
Yes, should be fairly effortless, right, or effortless. So with COPD, you lose that elasticity. Most often it's from smoking. There's some genetic causes, some environmental exposures as well, but most often from smoking. And we've lost that elasticity. So now air goes in, doesn't want to come out, and it takes effort. So that shortness of breath the patients are feeling in COPD is because they're breathing in, and now their muscles have to engage in a way that they otherwise wouldn't have to empty. So when they're
Takes more
exerting
effort.
themselves, so let's say they're going upstairs, carrying groceries. We all breathe a little faster.
Yeah, you need more oxygen.
But the problem is with COPD, you're breathing faster, but you're breathing in before you've had time to empty. So now that next breath comes, and you've stacked it, and the next breath, the next
And you
breath.
can't get the air out.
So you're full of air, and now you're short of breath because your diaphragm, the muscle that helps you breathe, is pushed all the way down. You're full of air. There's no room for more. So a lot of times patients will sit and rest and recover because their breathing has slowed down. They've had time to empty.
Yeah, and I noticed that with this chronic obstructive pulmonary disease, the COPD, there's a really other common names that people associate with COPD. What are some of those common diseases?
Yeah, so you hear the term emphysema.
Emphysema,
a lot.
yes.
And there's a lot of confusion when patients say, well, I was told I have emphysema, not COPD. So the difference is COPD is just the disease itself. I can't empty my lungs.
I'm obstructed.
That's why I'm short of breath. Emphysema is more of a radiology finding. On a CAT scan, like a special x-ray on a CAT scan, we'll see holes in the lungs.
The lung is breaking down.
Right.
Oh, okay.
So it's a finding, not necessarily the disease itself. So someone with COPD may have emphysema.
And they'll read that on their X-ray report if they're going into their
Correct.
patient portal. Yeah,
And there
they'll
are
see
some
that.
people, though, with emphysema on their CAT scan, like their lung cancer screening CAT scan. Maybe they don't have COPD, right? It's a radiographic finding.
Yeah.
COPD is the disease itself and the inability to empty the lungs efficiently.
And then you'll see that obstruction where people are getting short of breath, like you're describing. Is there also a coughing component to this?
Many patients have a cough, right? So especially if they're still smoking, which would be the most common cause. This chronic inflammation in the airways, mucus production. There are a number of people with mild to moderate COPD where they have a significant improvement in their symptoms after they've quit smoking.
Yeah.
But yeah, cough is often common.
Do they notice that this is not a sudden development of cough? This cough has probably been the morning cough they've had for months, and then it's a little more common. What is it that brings the patients to, say, urgent care? Because Lakeland Regional has a lot of urgent care areas, but you might be telling your primary care provider, "I'm having this." and they see these findings, what do you often see when you're first meeting that patient? What's some of their stories?
Yeah, so one, if they went to urgent care, a lot of times it would be frequent need for antibiotics, maybe wheezy on exam, that could be a clue. If it's more of a chronic issue, things like I used to be able to carry the groceries in one trip, now I'm taking multiple trips, or I get my kids to help me, or I used to take
And
the
this is
stairs
not
and
just
now
getting
I
older.
don't.
This is not, yeah, that's a really good point, is it's not you're just getting older. You've noticed that I used to do this, I can't do it anymore, and I really have to have that looked at. With that, you also mentioned that maybe even a common cold can hit you harder if you have COPD or this emphysema, bronchitis. What happens when you catch a common cold?
Yeah, so more airway inflammation, more difficult time emptying your lungs. So where maybe they in the past could have walked through a rhinovirus or a common cold, now it takes them down for a couple of weeks. Needed antibiotics, more mucus. Everyone in the house was recovering pretty quickly. It's lingering with them. Or a common story we'll get is, I feel fine most of the time, but when I get a cold, I really get a cold, and I take a month. That would be an example of probably a chronic bronchitis patient, which that's another subset of COPD patients, a little more coughy, a little more mucusy.
Yeah, and we often talk here on the show about the red flags to what to look out for, because there's mild shortness of breath or expected shortness of breath. If you go up a flight of stairs, we're all going to be breathing a little bit more. But I like that idea of just trying to keep track of what was I able to do before and I'm doing less, and actually finding out a little bit more about it. Is there other risk factors or things that folks should be on the lookout for? Because I have a feeling people are suffering and they don't really know what's causing it.
Sure. I think it's natural to not want to get checked out, right? Because it's
No news
like
is good
sweeping
news.
it under the rug, or yeah. So I'd say more often than not, it's family members that pushed it. It's a spouse. I've been telling you for months. You get it checked out. You look more winded, or it's the kids. Telling them to
Keeping
come
up
in.
with the grandkids, or
Yeah.
just trying.
So listening to the people who love you and that are around you and tell you something's different, that would be probably the biggest indicator. Someone needs to evaluate, are we missing something here?
Well, it's a quality of life too. If I enjoyed doing something, whether it's pickleball or just getting up and around, and now I'm finding I'm making excuses not to do it, or I'm not doing it. Yeah, you are starting to get out of shape, but it may have been caused by something that was treatable or recognizable.
Right. Yeah, I think that the common story is patients weren't aware. You ask them, when was the first time you even noticed any issues with your lung shortness of breath? A lot of times they'll tell you something like, a month ago, a few weeks ago, but you're looking at their CAT scan, their lung function tests, and you're talking to family. It turns out, 3 years, 4 years. So it's not uncommon, like I said, to not want to address it.
Yeah, and it often happens in the hospital, is that somebody has been going on for a long time like this, then they get that bronchitis you described, where it's like fever and coughing up yellow, and you're getting antibiotics, but then someone's looking at your chest x-ray or a CAT scan and says, the lung is breaking down, and your lung is larger than it should be, and air is obstructed and trapped. You need to start looking at the treatments for COPD, this chronic obstructive pulmonary disease. So with COPD, what are some of the first steps when you have that ability to say that the patient's now working with you and you're understanding what's most important to them? What are you going to offer, and what are some of the things you work together with the patients?
I mean, first, history, right? So you're trying to gather in the history, how likely is it this person has COPD as a reason for shortness of breath versus something else, into the list we mentioned earlier. Smoking would be at the top of the list, family history, there's some genetic, issues that we address. But let's say, it seems like,
Certain
this
jobs
probably
they did in
is
the
COPD.
past,
Yeah,
yeah.
great point. Then the first part of the workup and to get the diagnosis is lung function tests, which they might have had.
Is that how long you can hold your breath? No.
Yeah, right. They might have had some brief testing, maybe in their primary care clinic, with what we call a handheld
Yep.
spirometer.
You're
where they breathe
blowing
through this
into it or
device.
breathing into it?
Yeah,
or,
you're doing both. Those aren't usually very accurate. So what we would set them up with is a full pulmonary function test.
Yeah, I've heard these before. PFTs, pulmonary function test. That's sort of an appointment it takes, how long does it take to do really good pulmonary function
Good
tests?
30 minutes.
30 minutes, yeah.
30 minutes. It's a lot of maneuvers, but we get a lot of information.
Is that where you sit inside of a little chamber? I mean, they close the door, and so
Yeah.
and you breathe into something, and you have your nose clipped.
That's the one.
I did one then. I thought I got a kick out of it. It was sort of a neat test.
They're a little tougher than a lot of people think they would. A good respiratory therapist will really push you, but
Yeah,
when
because
you
you want an accurate result.
exactly, and then we could figure out: do you have an emptying problem, or do you have a lung filling problem,
Yeah.
or do you have neither? And it gives us clues to maybe something else to work up.
Because it's basically looking at how deep can you breathe in, and how fast can you blow out, and it's timed, and they're looking at the amounts of the air, and I just love the idea.
Yeah,
of
you
just
can measure
that.
the volume of your lungs at different points in time, which tell us different clues. We could even look at how efficiently you transport oxygen from
Yeah.
the air sacs into the bloodstream, and that gives us other clues. So, that's
So that's
gonna
a
be
good
the
first
first
step.
part of the test.
Yeah, so these pulmonary function tests, and that can actually help sort out what's underlying your sensation of
Yeah.
shortness of breath.
And that you would need to have a diagnosis of COPD. So a lot of times patients might have been labeled as COPD
Yeah.
and never had that test.
Or they thought in their heads that they just have asthma, and when you put all the information together, it wasn't asthma. It's a little more specific. That helps you treat them.
Yes. So if we identify, let's say this does go down the route of COPD, then we could start them on medications, which the way they work, if you think about it, you have trouble emptying your lungs.
Yeah.
If we could dilate your airways,
Yeah,
it
make these
drops the
tubes.
resistance, right? We're opening the pipes, then it's easier to empty.
Okay.
So first step is you get them on the inhalers that do that. So a lot of patients may have been given, say, an albuterol inhaler, and
Which is common in asthma. That's one
yeah,
of the
and
immediate-
the problem with that and stopping there is it's not going to keep that COPD patient out of the hospital. It's not going to keep them from getting short of breath in the first place. An albuterol inhaler is a rescue. Hey, I was doing this activity. I needed a little help to recover more quickly, and then I used my inhaler. But really, if they're short of breath and they're reaching for that thing more than once a week at most,
They have a chronic problem.
they need
yeah.
some maintenance therapy. So
Okay.
we have a great number of inhalers that last through the day.
And you
would use
can't
them
get
every
these over the
day.
counter. You really have to have the
Correct.
right one for you, medically discussed, and getting your feedback.
Yeah, and we have a couple options that, depending on the patient, can reduce hospitalizations, symptom burden, improve quality of life. So it is important to get that diagnosis right and get them on the right inhaler. And for the right person and the right inhaler, that's the difference between, sitting down versus getting up and playing with their grandkids.
Yeah,
Right.
and doing things to prevent, knowing what to look out for, like the fever or the changing color of the sputum you're coughing up, getting a flu shot, getting a pneumonia vaccination. At this point, no matter the age, you recommend a pneumonia vaccination?
Yes. Yeah. So these patients in general are going to be higher risk for complications.
If they get
if
pneumonia.
they get something.
or-
Yeah. So I usually will break it down for patients. My priority of vaccinations in order for what I see in the ICU and in the hospital. So pneumonia is important. I always push the flu vaccine is
Because you see some serious cases
we always
in the
lose
hospital.
a couple people. If you die each year from the flu in the ICU, it's always an unvaccinated person. So you can still catch it, but the people who get really sick are always unvaccinated. So it's flu. COVID, is infectious disease. It goes up and down with how serious it is. We're on a little bit of an uptick with some of the more serious cases where we had a bit of a lull where they were kind of mild. Pneumonia, RSV vaccine. So, when you get these vaccines, especially
Yeah.
if you have COPD or any underlying lung disease, you're much, much less likely to end up in the hospital.
And
which
they
is
saw
the
where
goal.
RSV could get children very sick and the vaccine for them, but as you get older, it's one of the tougher colds to sort of fight off. So to give your immune system a little bit of it's like seeing a wanted poster. It's like, be on the lookout for this germ, kind of thing.
Yeah.
So if you have COPD and you've got this chronic obstructive lung disease, it's one where you want to slow it from getting worse. Is there a role for exercise?
Yeah, great point. So actually, pulmonary rehab, we have I'm very proud of our pulmonary rehab program. That's been
Excellent.
a success. And we're actually expanding to a larger gym with the track because the demand's been very high. But pulmonary rehab is essentially getting a personal training session with respiratory therapists who are trained to teach you how to breathe with your lungs while doing exercises. And exercises are designed to strengthen your breathing muscles for your diagnosis. And we have patients in there with different diagnoses. That's been fantastic. Actually, I can't help
it
but
is.
gush
And
on the pulmonary rehab program.
When I was director of the health department, we had the Mary Sands Clinic, and it was in recognition of a citizen of Polk County who really felt important about, keeping this lung disease from shortening people's, not just lives, but just shortening their quality of life. And the Mary Sands Clinic, which used to be out in Auburndale, they would have the folks exercise, but it was very social. Folks got to meet, family would bring folks, they'd do the exercises, they'd get checked out, but it was a wonderful service. And so that kind of pulmonary rehab here at Lakeland Regional, where does that take place at?
Right now, it's at Hollis.
At the Hollis North Campus there
Yep.
by I-4.
And we're moving to the old Babcock Furniture Warehouse where we could expand. But yeah, it's of course a social hour, but I think in the right sense. I have patients who some of the patients know each other because of that, and they'll say, "Oh, you take care of so and so." He was talking about. So they do like going, but they work you. But it is important. Like so pulmonary rehab has been shown to reduce hospitalizations, improve quality of life.
Yes.
The difference between, like I said, I used to not be able to carry the groceries in, and now I can. A lot of that,
Setting those goals.
yeah, a lot of it is learning your lung disease, the techniques, and then those specific muscle groups that are trained. It's been real successful.
Yeah, and it's good that they have a good understanding, because it's been so helpful that patients have been able to ask the questions. Family members can ask questions. They can understand where it's going, and just to see where this disease is causing the lungs to break down and get larger. There are other causes of shortness of breath we wanted to mention, and one of them was the opposite. There are it's rarer. Tell us how common it is, where the lungs are getting scarred and they're getting stiff. And this sounds like a totally different reason to be short of breath, and it's not COPD. It's another kind. But tell me of that relation. You often find that folks may not have gotten diagnosed on that.
So interstitial lung disease is a big umbrella of about 200 diseases that diffusely affect the lungs, but essentially make them stiffer, versus COPD, which makes them kind of baggier and overfilled. A lot of people will initially be diagnosed with COPD just because it's more known. But if someone was, say, a never smoker or barely smoked, and they carry a COPD diagnosis, or they're on oxygen without a clear explanation and we're told maybe it was COPD, those are probably the stories that fit most of our new interstitial lung disease diagnoses. So that's a big red flag. And our staff, our nurses, or the rest of our team know when we hear that, the antennas go up immediately.
Just make sure we have the right diagnosis. And
it's incredibly, incredibly rare to truly have COPD and not have a significant smoking history.
Or had a job where you breathe dust
even
in
then,
all the time.
very rare.
Okay.
Even with secondhand smoke. Growing up, my parents smoked real heavily, kind of story. I understand it could contribute. It's still extremely rare to have a true COPD diagnosis that's symptomatic and especially needing oxygen without that personal significant smoking history.
So this separate disease that we're now talking about, unlike COPD where the lungs are breaking down, and unlike asthma where it's the air tubes, you said the word interstitial lung disease.
Yeah.
We're now talking about a different part of the lung. We're not talking about the air tubes. We're talking about the interstitium part. What does that really mean?
So if you think about your lungs, like the old car wash sponges, like the yellow ones with all the little holes in them.
Holes in it,
You could squeeze them, they expand. Your lungs look just like that if you take them out and look at them.
But all those little spaces are where the air goes. Yeah.
Correct. Yeah, so those are all air sacs. The interstitium is basically what wraps around all those air sacs.
The actual sponge itself in
Correct.
that. Oh, okay.
So diffusely affects the lungs because those air sacs are throughout.
Yeah, if you ever have a sponge that you can't squeeze, that's sort of what we're talking about with the interstitium.
Or maybe it's dried and contracted and can't expand.
And it can't, and so air can't get in. That to me worries me, and if I hear about a patient, tell me about some of the stories
Sure.
of where this is, because we're all talking about shortness of breath, but this is a little different cause, different feeling. Or?
So those stories often, like I said, start with a COPD diagnosis, but
Because
the
it's
rest
just
of
a
the-
common,
exactly,
or an asthma diagnosis.
and the
it's
rest
like,
of the history just doesn't fit. And
Yeah.
most often, they'll come in for shortness of breath, but when you really dig in, you find, well, I have had a persistent dry cough that my loved ones nagged me about
A dry
for the
cough.
past 2 years. Yeah, 2-3 years, and then finally we got checked out, or I got this X-ray and they said it looked abnormal. But oftentimes it's the cough preceding, and then the shortness of breath.
Tell me about the X-ray, because sometimes we have pre-med students watching our podcast, and when you think about the chest X-ray in emphysema and COPD, the lung looks broken apart, and those little air cells of the sponge you said are just bigger and bigger. What does a chest X-ray look like on an interstitial lung disease?
Yeah, so the COPD one, big lungs and a lot of blackness, right?
That's
Blackness is the
COPD,
air,
emphysema.
With the interstitial lung disease, often smaller lungs, and think about it, almost looks like spider webs through the lungs, on CAT scan or an X-ray.
Which
that's
is
more of a
the
spider.
material in between the little air cells.
Correct.
Okay. Does that mean they can't really take a deep breath in, or is it hard, or is it obstructive? It's actually not,
You
right?
can't fill. Yeah, the
cannot
opposite
fill
of
your
COPD.
lungs. And that happens slowly, and I can see the frustration in having that worsen. Is it important then to get this recognized early? Because you're mentioning the frustration, and there might be a delay in folks thinking it's asthma, thinking it's emphysema, but if they don't have the story that fits,
Sure.
what's catching this early?
So, well, one, getting chronic shortness of breath and frequent cough checked out and evaluated.
Because there's
so
many other
interstitial lung
causes
disease,
I've seen where
correct.
heartburn can be a cause of frequent cough.
Exactly. We get a lot of that in the pulmonary
reflux,
clinic.
reflux of stomach acid. Yeah. So find out the cause. Yeah. And
And then if it's interstitial lung disease, getting diagnosed early is helpful. In the older days, not even that long ago, probably just 20 years ago, the thought was interstitial lung disease, there's nothing we could do, hospice or transplant. There wasn't much. There's a couple drugs that were tried out that had worse outcomes, and finally we got some drugs that told the scar tissue cells to stop making so much scar tissue, and that preserved lungs longer. But nowadays, there's a lot we could do. We work it up differently. We have lots of anti-inflammatories. We'll talk about later when we talk about causes of interstitial lung disease. Even the scar tissue meds. We have a brand new med that just came out, and a fourth one probably on the horizon. We'll get the indication soon.
which
So-
sort of keeps you from forming scars.
In the
is
lungs,
the other term for scars is fibrosis?
Correct.
So these are stopping scars or the fibrosis, and that makes the lungs
Stiffer.
stiffer. And now you've got drugs that try to slow that down. What other things, that sort of is hoped for? Does a person need to go on oxygen?
If they require oxygen, with oxygen, the benefits are when you have significant desaturations in terms of mortality and outcomes. Some people, honestly,
So
they
you-
just feel better with some oxygen when it drops into the 80s.
Because you can that's that little red light you see on people's
Yeah.
fingers in the hospital, so you can see that that's measuring the oxygen level in your blood. If it's dropping down or they're having symptoms, putting the oxygen on helps them. That can help COPD, emphysema also, but it's also used in this disease.
Oxygen helps if your oxygen's low, but it doesn't slow or change
It doesn't
the
treat it.
process.
It doesn't treat the
Yeah.
process. Okay.
So the key thing with interstitial lung disease, let's say we identify it, then we have to figure out what's causing it. Something's causing this scar tissue or inflammation in the interstitium.
Yeah.
And that could be a number of things. It could be occupational exposures,
Something you breathed in.
sandblasting, concrete work, asbestos. We can usually get some good clues
Yeah.
by history, by
Jobs,
CAT
they've
scan. Yeah, and that can sometimes just kick off this process with those scar tissue cells that, they don't slow down.
And they basically bump out the air cells.
And then some people, it could be from rheumatology causes. So a lot of rheumatologic diseases, if you think about rheumatoid arthritis,
And these are
psoriasis.
diseases that are your own immune system is attacking
Correct.
and so this is where interstitial lung disease may not be just involving the lungs. You could be having something that first was irritating your joints, and it just moved to starting to.
Yeah, so I usually explain to patients, one, just what the immune system is supposed to do, and then when it goes awry. So
Yeah.
what it's supposed to do, if you say, like, let's say you came in here with the flu, and you coughed it on me, my immune system, my B cells, B as in boy, would see that new flu virus, study
It
it,
shouldn't be there.
make a sticky protein called an antibody,
Antibodies.
designed to stick just to it. That sticks to the flu, and that's like a homing beacon for all the killer cells that really will get rid of it.
That's part of your immune system.
So that's a normal response.
normal immune system.
Sometimes those B cells, B as in boy, who make those antibodies, they get confused. Maybe at the time when they were making that flu antibody, they twisted that protein just the right way, where now it's sticking to, say, the joints. That's rheumatoid arthritis, right? Like it's sticking to the joints. Now your killer cells think your joints are the flu and attack it. Or other
and then
ones.
that gets an attack is inflammation. It gets painful, red, hot, warm. Okay.
Yeah, people with Graves' disease, the same thing with the thyroid, or people with Sjogren's, sticks to salivary glands.
And
tear ducts.
scleroderma, you mentioned, the skin and the swallowing tube.
Correct.
So there's these diseases where your immune system goes awry and starts to irritate
Gets
your own
confused.
tissue.
Yeah, it makes antibodies inappropriately that stick to your own body. Well, the lungs, if you think about that sponge, it's a tremendous amount of surface area. There's a lot of cells in there, lots of spots for these antibodies to stick to. So it's not uncommon. In fact, I'd probably say in our clinic, most of our interstitial lung disease patients, it's a rheumatologic or immune problem where the immune system got confused. So commonly, we'll find rheumatoid arthritis antibodies, even in the absence of joints, because sometimes
But
they
the
can affect
lungs
the
are
lungs
getting-
first.
Okay.
Myositis are a group of rheumatology diagnoses where the immune system attacks the muscles. Those love to attack the lungs as well. And sometimes it could start with the lungs years before you have other symptoms. So we work all of that up. And the management that's changed, especially with new guidelines even this year, we have all these wonderful immune suppressants that thread that needle of telling the immune system to stop making those bad antibodies that stick to the lungs. And we balance not overly suppressing the immune system to the point where you get too high risk of infection, but by addressing that, identifying it early, before the inflammation led to scar tissue, we can hopefully reduce the inflammation, improve their cough, shortness of breath, prevent that production of scar tissue.
And you made the best argument to getting this recognized earlier, having family notice there's an issue, having you notice, and get the treatment early, because scars are hard to
You
reverse.
can't undo it once it's scarred, But the inflammation, you can. So there'd be a lot of people, when we get the right drug, and oftentimes working in collaboration with our rheumatology friends in the same building as our ILD clinic, when we get the right drug, we could reduce that inflammation and improve those symptoms. And while we may be left with some residual scar tissue, a lot of times those patients, we could get them stable so they don't continue to progress, and their symptoms improve.
Yeah, and being able to get back that quality of life, but also realize, what other steps have to occur.
Have a name to their diagnosis, right? So as new things come out too, we can address it. I always tell patients not to Google interstitial lung disease in particular, because again, like I mentioned, 20 years ago, we didn't have all these options.
Right.
So there's nothing you could do
You'll
for the
get
most
that
part. You just
information
throw up your
with
hands.
that,
But commonly they'll come, for whatever reason, the same statistic keeps coming up, that you're going to die in 3 to 5 years after diagnosis. And that's from an old, outdated paper before we had all of these medications. The workup was different, but for whatever reason, that's the first thing that pops up in Google.
Well, and it's the scariest thing, but it's being able to have you and your expertise and your team at Grasslands to be able to give the patient sort of that ability to ask the questions and be ready. You've got a great team at Grasslands. That's at the corner of Hardin and Edgewood.
Yes.
Yep. And I think the pulmonary rehab areas that we have, and that's, I think the locations will be good to be looking at how you get that stamina, back. But I know it gives you a lot of good information that the families can be focused on. Well, I appreciate all the information. This has been helpful to know that there's lots of things that could cause shortness of breath, get the expert opinion, and I'm glad you work so closely with our primary care physicians, because, the ability to communicate early and find out what's going on is helpful.
Yeah, great.
Terrific. Well,
Thank you
thank
for
you very
having me.
much.
Yeah.
Thank you.
Sorry.